Good afternoon, everyone. Let me briefly tell you about my PhD thesis. I'm working on novel therapeutic approaches in sleep-related breathing disorders. My name is Bardóczi. I'm a pulmonology resident in the Department of Pulmonology, and I chose this topic because during my work I meet many patients who are dealing with sleep-related breathing disorders, which destroys their quality of life, so I would like to improve on that. And our research team working to find the best therapy to reduce the symptoms and the severity. As you can see, we have two specific ongoing projects which address to this problem. My first project is investigating the effectiveness of GLP-1 analog in obstructive sleep apnea patients. Obstructive sleep apnea is a serious sleep disorder that involves the upper airways collapse during sleep. 1 out of 4 people are affected, and it has several negative health effects, including the early death. Severity is measured by the apnea-hypopnea index by counting the numbers apneas and hypopneas during sleep. This table shows the classification based on the severity. In the severe cases, we usually treat it with the continuous positive airway pressure therapy. The biggest risk factor of obstructive sleep apnea is obesity. 58% of the cases are linked to excess weight. Therefore, weight loss is also recommended for this patient. The good news is that we have some novel pharmacotherapy choices for them. I think most of you have already heard about the glucagon-like peptide-1 analogs. These medications can downregulate your appetite, can reduce adipose tissue, while protects against cardiovascular diseases. This diagram below shows how the drug was effective in weight loss treatment. But how they can work in obstructive sleep apnea. We know weight loss is recommended for obstructive sleep apnea patient, and we know the GLP-1 analog can help with weight loss, so this is one way. Furthermore, they can improve airway collapsibility and has direct airway action. The diagram below shows how the drug was effective to reduce the severity of the disease, but unfortunately these medications haven't been implemented in the clinical practice yet, so our aim is to investigate that the GLP-1 analogs are effective treatment choices in obstructive sleep apnea. Our clinical question is, can GLP-1 analog reduce the apnea-hypopnea index, thus leading to improvement in obstructive sleep apnea patient? We work with the PICO framework. Our patient population is obstructive sleep apnea patient, and we want to compare the GLP-1 analog as an intervention with the standard of care. Our primary outcome is the apnea-hypopnea index, which measures the severity, and our secondary outcomes are body weight and body mass index. So our hypothesis is that the GLP-1 analogs can reduce the apnea-hypopnea index, and our clinical implication, weight loss therapy with the GLP-1 analog as a standard of care for patients with obstructive sleep apnea. Here you can see my finalized search key. I did it in 3 different databases. First in November 2023, and I repeated it in last year in the end of June. And after the flowchart of the selection, we have 5 eligible full text to analyze. And now we can move on my result. In my first figure, you can see the overall changes in apnea-hypopnea index among those who are receiving the GLP-1 analogs. In this forest plot, you see 6 randomized control trials, included over 500 patients, and the mean changes of the apnea-hypopnea index is over 14. The confidence interval of the mean falls within this range are shown in the red box. And so our results are mathematically significant, but based on the table below, our results are clinically significant as well. In my second figure, you can see the changes in the apnea-hypopnea index between the GLP-1 analogs group and between the standard of care groups. In this forest plot, you see 5 randomized control trials, included almost 1,000 patients, and the mean difference of the decreasing in apnea-hypopnea index was over 11. The confidence interval of the mean difference falls within this range, so our results are mathematically and clinically significant as well. In my third figure, you can see some of my secondary outcomes. In this figure, you see the changes in the body weight between the GLP-1 analog group and the standard of care group. In this forest plot, you see 4 randomized control trials, included over 800 patients, and the mean difference of the decreasing in body weight is over 11 kilograms, and the mean difference of the confidence intervals falls within this range, so our results are also mathematically and clinically significant. And in my last figure, you can see the changes in the BMI between the 2 groups. In this forest plot, you see only 3 randomized control trials, included over 500 patients, and the mean difference of the BMI decreasing is 1.7, and the coincidence interval falls within this range. It's clinically a little bit significant, but it's mathematically a significant result as well. So we have some strengths and limitations. Our biggest strengths, we work only randomized control trials with increasing the quality of the evidence. We work with the clinically important follow-up time, and we do a very broad and comprehensive search. But we have some limitation. We found a few studies, but honestly it's a very novel field of research with a relatively small patient population, and another, I think, biggest limitation, we only able to analyze 2 GLP-1 analogs. So after that, we conclude the GLP-1 analog can significantly improve the apnea-hypopnea index and reduce the severity of the disease. So our implication for practice, use GLP-1 analog as a standard of care. And our implication for research, we need more comparative randomized trials to further optimize the therapy and a higher number of patients to reflect the real-life prevalence. So just yesterday, we submitted our revision in Sleep Medicine Reviews, which is a D1 journal. And now I can move on my second project, which is comparing the effectiveness and safety of positive airway pressure therapies in Pickwickian syndrome, which is also systematic review and meta-analysis. But what is Pickwickian syndrome? Pickwickian syndrome was named after one of Charles Dickens' famous character, Mr. Pickwick, who has some typical features. He's obesity, sleepiness, snoring, and dropsy. But what it means clinically? In the last few minutes, I talk about obstructive sleep apnea a lot. It's a serious sleep disorder that involves the upper airways collapse during sleep, and we came another sleep-related breathing disorders, the obesity-hypoventilation syndrome. These patients suffer from obesity, are hypoventilating during sleep, and because of that, they have daytime hypercapnia and hypoxemia. When a patient has both together, we can call them Pickwickian syndrome patient. Without treatment, they get serious complications such as high blood pressure, right-sided heart failure, pulmonary hypertension, and depression, and so on, and fourfold increase in mortality risk. So we have to treat it. We usually treat it with the positive airway pressure therapy, and in our meta-analysis, we want to compare these two, the CPAP with the BPAP devices. But what's the difference between them? The CPAP therapy stands for the continuous positive airway pressure therapy. It works with a single set pressure, blows constant pressure when you're breathing in and the same pressure when you're breathing out. Not as great for accommodating breathing changes, but more affordable and simpler to use. What about the BPAP therapy? BPAP therapy stands for the bilevel positive airway pressure therapy. It's works with 2 distinct pressure settings, blows higher pressure when you're breathing in and blows lower pressure when you're breathing out, often used to treat more complex sleep and breathing disorders, but it's less affordable and more complex to use. So our aim is to investigate that the CPAP devices are effective treatment choices in Pickwickian syndrome. Here you can see our clinical question, which is can the CPAP therapy be an effective treatment choices for Pickwickian syndrome? Our patient population are Pickwickian syndrome patients. We want to compare the CPAP devices with the non-invasive ventilation devices. Our primary outcome is the arterial blood gas parameters, and our secondary outcomes are mortality, hospital resource utilization, respiratory function, sleepiness, quality of life, and safety as well. And our hypothesis is the CPAP treatment is an effective treatment choice for Pickwickian syndrome. And our clinical implication is CPAP treatment is an effective first-line treatment for patients with Pickwickian syndrome. Here you can see my finalized search key. I did my search in 5 different databases. And after the flowchart of selection, we have 6 eligible full text to work with. And now my second project progress, I'm finished the data extraction part, so now we can move forward. And I want to finish my presentation with the word of famous physicist George Gamow. Science is not just about knowing things, it's about asking questions and pushing the boundaries of the knowledge. And thank you for your attention.
Thank you for your presentation. I just would like to ask about your second project, if there was any age restriction regarding to the population, at which age you involved from the Pickwickian syndrome patients?
It's only adult patients we include in the inclusion criteria. If I remember well, we don't set up the highest age, but in the text, what I see, it's set up at 75 years old. So they maximized this 18 to 75.
Thank you very much.
One question, is the BPAP is better than the CPAP? Are there any significant difference regarding the results?
What we see, we don't have the finalized result, we only have the extract data, but we see and the text see, what are we see in the text, they are kind of similar in when the patient have a severe obstructive sleep apnea. So in that case, the CPAP some case works better for them when they have a severe obstructive sleep apnea in Pickwickian syndrome. So what we see, but they similar.
So with CPAP, what I see is that one of the biggest challenges is patient's compliance with CPAP. It's extremely uncomfortable, also for the family. It's often quite noisy. Do you think BPAP is a little bit more comfortable for the patients?
It depends on the patient, but when we talk about this whole thing with the patients, which is better, and we see the prices, it's different. So for the first line, I think we can try with the CPAP, and when a patient don't like it, has a big compliance with this CPAP machine, then we can change for the BPAP. But the BPAP is also very loud for the family and wives and so on. So I think it's very loud as well, not only the CPAP. And it depends on the mask. So we can change the mask to find the best mask to treat it with. So.
And do you think GLP-1 analogs would work similarly well with Pickwickian syndrome patients?
I think yes, but we don't find any article about this patient population. But I think because they are obese, and the weight loss therapy is not only help with the upper airway and so on, but they also can help to when you lose weight, it's help everything in your whole body, so reduce the inflammation, lower your blood pressure and so on, so the overall benefits are higher in that case.
Well, I have two questions, in fact. One is that in your first project, the BMI drop was negligible, whilst the improvement in the hypoxemia apnea index was enormous. I mean, 15, 11, that means at least two stages
yes.
Improvement. How do you explain that? And my second question is the GLP-1 analogs.
Yes.
Have you looked into any adverse events? So these are the two.
Okay. For your first questions, I can say the biggest difference what you see, we work only to GLP-1 analog, the liraglutide, which is only a mono GLP-1, and tirzepatide, which is not only GLP-1, it's also a glucagon-dependent inhibiting polypeptide. So it has two effects, and when you see the apnea-hypopnea changes overall, they get this study which included the tirzepatide. And in the BMI phase, we only get the results from 3 papers, and for 2 papers make it type 2 diabetes in China. So they don't have the big BMI index, so they drop to 27 to 25 or something, and this makes the biggest difference what we see. So with the tirzepatide, they get the bigger weight loss as well. So that is my first question. And the second question, we don't have enough data for the safety in the obstructive sleep apnea patient, because these medications are made for treat the type 2 diabetes. And the GLP-1 analogs has a different effects on the patient, different effects on the weight loss. And we don't have enough data to go deep into the safety measurements, but what we see, most of the patients, when we used in the license indication, has only neglecting adverse events like vomiting and nausea and diarrhea, but after that they are these adverse events are go through, so they don't have after that.